Professor Lavender is a professor of maternal and newborn health at the Liverpool School of Tropical Medicine. She is also director of the NIHR Global Health Research Group on the prevention and management of stillbirth, working in sub-Saharan Africa. Welcome, Professor Tina, and over to you.
Thank you very much, and it's great to be here. I'm sorry that I can only be here for a short period of time because I'm actually on the India Birth Network meeting at the moment, so I've just nipped out for a short period of time. So I'm going to talk to you about... Gosh, a lot of background noise. I'm going to talk to you about birth companion and respectful labour care and why it's so important. But I must say that listening and viewing that video that was shown by Sudin, nothing that I say can be as powerful as listening to women themselves. So I hope that this will just complement what you've already witnessed today. So why are we talking about this? Well, we're talking about this because women are still receiving disrespectful care today. And this comes in many different guises. It can be physical abuse, verbal abuse, discrimination, lack of privacy, isolation, and many other ways that women are actually disrespected. And we know that it can have a wide impact. It can impact on whether the women decide to access facility care in the future. It impacts on their psychological well-being, and it also impacts on clinical outcomes. So it's great that it's incorporated within the PREVENT bundles. And very little attention has been given to respectful care of the newborn. And this is something that we're all trying to address. So let's have a look and see what women actually want around the world. And this was a campaign that was led by the White Ribbon Alliance. And they did a huge survey and they found the views of more than 1 million women and girls across 114 countries. And they asked about what they wanted most related to reproductive health and maternity care. But they didn't just send out a survey, they were actually knocking door to door and getting people's views. So it was a really impressive piece of work that accessed some of the most vulnerable women across the globe. All women gave informed consent, and the survey also had open-ended questions as well as closed questions. And as I say, they did lots of outreach to access as many women as possible. And one of the questions that they asked was, what is your one request for quality reproductive and maternal healthcare services? And from this, they developed 38 categories highlighting their main wishes. And if you haven't already accessed this dashboard, you can just go on and have a look. It tells you the different countries, the comparisons, and I've given you the link there if anybody wants to use it. So I've looked at the women from India and looked at that in comparison to all women. You can see here related to the age that there's no difference. And you can see that the Indian women is in the red and all women are in the blue. And you can see here that Indian women mostly mentioned equity, dignity and respect as a thing that they most desired from reproductive and maternal health. This was no different to all women. So this was the top answer throughout. And then if they drill down a little bit more into this, you can see some of the supporting things that was said. I mean, some of these I would have perhaps merged a little bit because I think a lot of them are related. But you can see that things were important, was waiting time, non-discriminatory behaviour, good behaviour. This was from healthcare workers. They talked about the physical abuse that they were experiencing, that they didn't want to happen anymore. And you can see from these collection of words that these are the things that really mattered. But if we look at the qualitative, it gives us a little bit more insight. And these were the verbatim quotes. So people said equality, no discrimination by the staff on basis of class, caste or religion. polite staff of doctors and nurses, no physical abuse. Sometimes the providers physically assault us. Birth companion of choice, they need to respect our choices during childbirth. And if we look at that survey and then we look at the global situation, you can see that it's pretty similar. And this was a review conducted by Sue Down and colleagues that looked at what matters to women during childbirth. And this included 35 papers across 19 countries. India and the UK were included within these countries. And this was Sue's conclusion, that positive experience that fulfilled or exceeded their prior personal and social cultural beliefs and expectations, that was what mattered to women. And they wanted to be psychologically safe environment, they wanted support, they wanted birth companionship, competent, reassuring and kind clinical staff. And this kindness comes up over and over again in any research that is done around what matters to women. And then the other thing is control and active decision making. So wherever you are in the world, this is what women want from their maternity services. If we look at another important piece of work, this was qualitative evidence synthesis that looked at health facilities and respectful care. And they included 67 studies from 32 countries. And they found that these were the things that mattered and that we should measure our care against. So being free from harm and mistreatment, maintaining privacy and confidentiality, preserving women's dignity, informed consent, continuous access to family and community support, enhancing quality of the physical environment and resources, equitable maternity care, another one that comes up over and over again, effective communication, respecting choices, competent and motivated human resources, continuity of care and provision of efficient and effective care. And I think that everybody on this call today will agree that these things all really matter, and these are the things that women deserve when they come into any facilities that we are working in. And these things have fed into the WHO intrapartum recommendations. And I know that many of you will be familiar with these, but they had a real paradigm shift in where they're really promoting the positive childbirth experience, as well as important clinical outcomes. This all kind of rests around woman-centred care, individualised care. And you can see some of the same things that's in the evidence coming up here: competent and motivated staff, supportive care, labour monitoring, referral plan. And you can see within this circle as well, it's birth companionship, etc., etc. So all these things are now tying up and giving a real presence and an emphasis to make sure that women do receive that care that they deserve. And individualised care is key to this. There has been an acknowledgement that every birth is unique, and some labours progress quickly and others don't. We heard from Sue Din about the Labour Care Guide and how that is aiming to only intervene when necessary and not to have that standard alert and action line that's going to be applied to every single labour, because we know that women do labour differently and their care should be guided appropriately. We also know that all women have a right to a positive childbirth experience, and this includes respect and dignity, the companion of choice, clear communication, clear pain relief strategies, mobility in labour, and their position of choice. So how do we deliver what women want? Well, if we look at the WHO framework, quality of care for maternal and newborn health, it's a few years old now, but it's still very relevant. I think that historically, what we have done as healthcare providers is very much focused on the provision of care. So these are the things, the evidence-based practices, the treatments, the things that we do, and the task-orientated work. Whereas we've given probably less emphasis to the experience of care. And I think that to give adequate quality of care, we really do need these two things to work hand in hand. And I think that is the key to how we deliver the optimum care for all women. I'm going to just tell you a little bit about one of my studies, which was a grounded theory study in exploring intrapartum experiences in Zambia and Tanzania. Just to evidence the fact that this is an issue in many parts of the world. And we interviewed 98 participants, and our main findings were that respectful care is marginalised by women and health providers. And as I said when I was talking about the previous framework, health providers gave greater priority to the delivery of care as opposed to the experience of care. We also found that social discrimination underpinned the perpetuation of disrespectful care, and this was through both conscious and unconscious health provider bias. And what we found was that transactional care, that is giving the treatment or procedure, was given much higher priority than relational care, that is talking to the woman, building up that relationship and getting women to feel safe within that environment. And just to show you a couple of the verbatim quotes from this, you can see this was a partner following a stillborn baby in Tanzania, who said, "A villager can go to the hospital with torn, dirty clothes, and the nurses will hardly look at you. Therefore, those who dress better and apply scented ointments get priority, and this discrimination is discouraging. Then others have been served. They now ask questions. What are you doing all day here?" So not very nice treatment. It deters those from attending the facility. This was a health provider from Zambia who said, "We need to be welcoming, respectful and kind as health providers. We should treat everyone the same, regardless of their race, creed, tribe or colour." I just want you to reflect for a minute on your own care, or if you're a parent, your own experiences, and stop and think how women must feel. They enter a facility that's very alien to them, and we have these kind of hospitals, you know, in the UK, in India, in parts of Africa, where I work, and this is what women see when they first come. It's not very inviting at all. You go into the facility, you see lots of people milling around, everybody seems busy, you see equipment, curtains, and it's a very, very scary environment for women, and we probably don't do enough in order to welcome them and to make them feel comfortable. And then the way we look ourselves, our own appearance, how do we welcome them? Do we welcome women with a smile? Do we introduce ourselves? Do we say, "Hello, my name is Tina. I'm your midwife who's going to be looking after you today. You know, do you have any questions?" Or do we look like this health provider here? Do we penalise women if we keep asking for help? On that video, the woman said she didn't like complaining. You know, are we mindful of this? And are we thinking about the woman, how scared she may feel? Do we actually listen to women? Or do we just bypass them and not adhere to their requests? And I think that, you know, when we're busy, it's very easy to do all of these things, but maybe we should reflect a little bit more on our own practices. And also the other thing is that, who are these people? You know, if they're not introduced to you and don't wear a label, how do you know who's the cleaner, who's the nurse, who's the midwife, who's the doctor? I think we should make that a little bit clearer. We also should be wary about the language that we use. The language that we use in medical terms is not always familiar to women. You know, we talk about the primary, the multi, the fundus, the section, the BE, the LOA, LOP, FHO, FMF, LRM, Catholic. You know, all of these words, you know, do we use plain language in a way that women can actually understand what we're saying, so they can answer appropriate questions in order to give informed consent and be part of that decision-making process? That's something else we really need to think about. The other thing that can be really helpful is a birth companion for many reasons. One of the reasons is that they can actually act as the middleman to communicate necessary to women and health providers. And you can see here that WHO say that allowing and supporting the presence of a woman's companion of choice is an effective intervention that is respectful of women's autonomy and agency, and which can therefore be an important aspect of improving quality of care during labour and childbirth. And again, this is an example from some of my own research. This was a woman who was birthing alone, and she talked about the fact that she was helped by somebody who was in the next bed, because she was birthing alone. There was nobody there, nobody to go and call for help, and the baby had already come out before she even knew about it. And she was saying that if the doctor had been there, she might have received assistance, and the baby had actually died. So there's lots of incidents of this. If a birth companion had been there, then maybe the birth companion could have got the help that's required. And if we look at the evidence around birth companionship, if we go to the Cochrane, which is the best source of evidence that brings together all the papers related to the subject. And this Cochrane review assessed the effects on women and babies of one-to-one support in labour, and they compared it to usual care and looked at lots of different settings. And their results, which included more than 15,000 women from 26 trials, showed that birth companion providing one-to-one support during labour reduced the caesarean section rate, increased the spontaneous vaginal birth, reduced low at-birth scores, so babies were in a better condition, reduced the time from birth to the initiation of breastfeeding, which we know is very important, and it reduced negative ratings about childbirth experience. And the subgroup analysis suggests that the findings were similar, regardless of whether the study took place in a high or a middle income country. There weren't actually any trials in a low income country that were included. And then another Cochrane review that looked at the qualitative evidence around companionship, and this was by the same team. And they included 51 studies, and they were mostly from high-income countries. And they found that labour companions supported women in 4 main ways. Firstly, they gave informational support, provided information, facilitated non-pharmacological pain relief, so this was massage or helping them to be mobile. They acted as advocates, speaking up for the women. They provided practical support, and they also gave emotional support, so praise, encouragement, and just being there, having a presence was very helpful. And the review concluded that further research, especially in low middle income countries and with different types of staff, could strengthen the evidence. And they also suggested that prior to implementation of labour companions, that there are several factors that should be considered. Training and content and timing for providers, women and companions, so that they all need to know what their role should be. And the physical structure of the labour ward needs to be considered. There should be clear roles, and there should be integration of companions. They shouldn't be outside the team, they should be integrated. And there should be ways of measuring the impact of companionship on women's experiences of care. I know from your own QI programme, they talked about the presence of companion during labour, and that there were targets, that 50% of births take place in the presence of birth companions, and at least 90% of births are attended by a birth companion. I know that in India, I know that you do a lot better than a lot of the countries that I work in sub-Saharan Africa. I wonder whether we do enough to support those companions and to make sure that everybody knows what the roles are and how to do it effectively. So in conclusion, I would just like to say that, I think we should all acknowledge the issues raised by women in the White Ribbon Alliance survey. And as I said previously, if you haven't accessed that dashboard, please go in. You can compare to different countries. There's lots of data in there that's really enlightening. Use the evidence to inform workable strategies for birth companionship. As we know, it's important. The evidence is very strong. We need to work together to deliver what women want. And I do believe that the PREVENT study can help us with all of these things, and is doing amazing work to make sure that respectful care in particular is embedded throughout all of the work streams and all the work that's being conducted. So thank you very much for listening.
Thank you so much, Professor Tina, for that very insightful session. If anyone from the audience have any questions, kindly post them in the chat and we can take them. And meanwhile,